Hello, everybody. Thanks for having me. I'm Matt Weber. I'm a third-year resident at Virginia Commonwealth University. So happy to be here representing VCU and representing the small cohort of hand and peripheral nerve basic science surgery today. And there's no hydraulic sitting stools around, but I think I can stand for 5 minutes. So, should be good. So I did my work in Dr. Isaac's lab, Jonathan Isaac's, looking at nerve perfusion in tensioned repairs. And actually have some new outcomes data from this past week that I've added into the talk. I'm excited to share with you all. For some background, there's a dogma in nerve repair that repairs under tension should be avoided at all costs. And that's backed up by some of the data, but it is sort of a big assumption that we have. There is some limited data from rat surgeries and sciatic nerve repairs that there might be some upper limit somewhere between 6 and 9 millimeters of a gap. And then you start thinking about using things like grafts or things like conduits. But there is still just this stigma against repairs under tension. Part of why that's theorized to be an issue is maybe because the tension decreases blood flow. But the data that we have for that from the early 90s was in nerves that were being stretched outside of the body, not nerves that were repaired. And so you do see with increasing stretch, you get decreasing blood flow that you can see with a laser Doppler. But we don't actually have data about nerve perfusion after a primary repair. So, I think it's important to challenge assumptions that we have that, we assume this transitive property here will hold and repairs under tension will have decreased blood flow, will have worse outcomes. But I thought it was important to identify that missing link, and so I designed a study to kind of prove that all of these things are true when put together into one cohort. So 30 rats we used and identified left sciatic nerve, did the right sciatic nerve not as a transection or repair, but just as a control for the perfusion, and divided into 3 groups kind of based on some of that preliminary data from other institutions. Went for a zero tension repair, which truly you'll never have in real life, but then a 4 millimeter segment resection and then primary repair, and then 8 millimeter segment resection, primary repair. And to avoid any skewed results, a standardized amount of the nerve was mobilized because as nerve surgeons you would mobilize the nerve to relieve some of the tension, but we did the standardized amount of mobilization, and then took laser Doppler measurements. So we measured it before cutting, before doing any surgery on the nerve at all, mobilized the nerve to kind of get it ready for transection and repair, and then immediately post-repair, 5, 10, and 30 minutes post-repair, checked the perfusion with the laser Doppler, and then came back for a functional studies surgery 12 weeks later and got perfusion data again at 12 weeks post-repair. For some more functional outcomes, we collected gastroc and sciatic nerve tissue, which is being sent off for histology. So those results aren't ready yet, but measured the muscle weights of the gastroc and the muscle girth, and also collected walking data you can use to calculate the sciatic function index, as well as some electrophysiologic data on twitch strength and strength of the muscles when undergoing a tetanic contraction, sustained contraction. So for the results, stretching the nerve across a large defect actually did significantly reduce the perfusion in the nerve at all time points after the nerve repair was done. Interesting, mobilizing the nerve didn't really change the perfusion that much, so it really is some sort of intrinsic blood supply to the nerve that does get tensed and compressed that is likely explaining a lot of this. And there was, some limited recovery of perfusion within that 30-minute window that we monitored after the repair, just because of some of the stress relaxation most likely. But still, at every time point, significantly, decreased perfusion the more tension you had. At 12 weeks, they all recovered to the same, robust response to injury. There was actually a hyperperfusion relative to the other side. So no differences there at 12 weeks. They all seemed to do pretty well as far as perfusion. For the muscle weights and muscle girths, the 8 millimeter group did have a significantly lower weight and girth relative to the low tension group. The 4 millimeter group, kind of in keeping with some of the literature that's already out there, didn't actually show a significant difference compared to the no tension group. So some amount of tension does seem to be tolerated for those metrics. I thought it would be interesting just to look at the direct correlation between the perfusion that we noted after repair and the ultimate muscle morphology. There's a weak trend, admittedly, and I'd like to get more data, and I wish there was a Pearl Diver database for rat perfusion, but unfortunately it's just these 30 guys that we have to look at. But I think seeing a more clean line would be very nice here if we had a few more samples. And then looking at the actual muscle strength, not just the morphology, similar trends kind of appeared, really only in the tetanic contraction. The twitches all pretty much looked the same for a very brief pulse, but with tetanic contractions, we did see decreased muscle strength, likely due to increased fatigue when you apply tetany. A little bit flatter of a line here for the perfusion versus ultimate muscle strength. So in conclusion, we did sort of validate what was thought, that if you repair these nerves under tension, you do get decreased perfusion, and that goes away at the 12-month mark or 12-week mark. But there's probably some critical ischemia time between repair and 12 weeks where the blood flow does matter and does affect recovery. And we saw that in the muscle girth, muscle strength, and hopefully we'll see that in histology and the sciatic function testing as well.